I was recently asked by a viewer of the connection between statin use and colitis and glaucoma. So today I'm going to take a look at that. And we're going to look at a bigger issue that this whole question raises. Stay tuned. When I looked up information on this subject, I came across a lot of papers about it. We're just going to take a look at some of them. There are papers and articles that would tell you that statins cause colitis. And there's a list of them here. You can follow the numbers in the video description to read the articles if you so desire. There are papers and articles that will tell us that they help with colitis and related issues. There are papers and articles that tell us that they have no effect on glaucoma. And there's papers and articles that say they actually help prevent glaucoma. So at the risk of oversimplification, I'm just going to do a quick overview of each of these articles. In this first case, under they cause colitis, there was a case study that definitively showed that simvastatin induced the colitis. It took them a while to recognize that. And that's always a problem with these less common effects. I wonder how many other adverse effects go unrecognized for long periods of time and never actually get pinned down on the statins when it's the statins that did it. Next article, mentioning that simvastatin and atorvastatin associated with increased occurrence of this microscopic colitis condition. Another one was a secondary source kind of citing the same things. There was a whole list of medicines that can cause colitis, so I suspect that papers 3 and 4 are actually pointing back to the same source. And then there was a case study in which the patient actually died from the ulcerative colitis complications, but I guess from post-mortem they were able to determine that it was actually statins that had done tremendous damage to this person and basically killed them. On the side arguing that they help with colitis and related issues, they did find an association with cancer risk reduction in patients with ulcerative colitis who were on statins. The number needed to treat was 200 over 10 years, and this was actually cited as the most solid evidence that we really should be using statins to help prevent cancer in ulcerative colitis patients. 200 people would need to be treated for 10 years to avoid one case, and that is cited as strong evidence. I just wonder if these people are actually dealing in the real world and view the world the way the rest of us do. Next article was a secondary source. It was a rah-rah popular press article. It claimed that statins help with colitis. They didn't cite any relevant statistics, though they did cite quotes from various different doctors. Next article, there was a brief mention of statins being used on patients who already had colitis or irritable bowel syndrome. In their case, they were still presenting statins as wonder drugs and listing all sorts of things that they could help cure. Again, very minor effects, and I just wonder what world they're living in. So moving on to glaucoma, this paper indicated that there was small and inconsistent data that could indicate that it could help, but they said the evidence was very weak and the clinical studies weren't designed well to prove that. The next one found that there was no association between statin use and primary open-angle glaucoma. In fairness, I did look at the confidence intervals and data. It didn't meet that 95% confidence interval criteria where both ends of the confidence interval would have to be under 1 to show that there was a reduction. It did lean a little more towards glaucoma reduction than against it. It didn't meet statistical significance in that case. In this other paper, this was a letter to the editor to one of the journals, and they pointed out that higher statin dosage resulted in a higher risk of developing glaucoma. I didn't chase down all the references in that, but it appears that there are enough studies showing that higher dose statins mean higher incidence of glaucoma. On the side for helping prevent glaucoma, that same paper that noted that the data was inconsistent did note that there's a 2 to 7% relative risk reduction in OAG among patients who have hyperlipidemia who are taking statins. That 2 to 7% relative risk reduction, just say it's 5 as the average. That's not a very good relative risk reduction, especially given how relatively rare OAG actually is, and we'll get to that later. On the other hand, in that same letter to the editor that I mentioned earlier, they did point out that high triglycerides are a contributing cause to OAG, and that would be treated somewhat by statins. This was probably the strongest one that I found for statins having any positive impact on glaucoma. They did point out in some studies a risk reduction over relatively short periods of 4% per year, and it went up to 8% after 2 years. Now, if it kept on with that trend, that would be significant after 10 years, 40% reduction in OAG. They couldn't make that claim, and they didn't try to make that claim because they basically took the standard, well, we need more study to see this. But those would be signs that indicate that glaucoma could be helped from statins. statins. There's just as many signs that say that glaucoma is hurt by statins. So there's a fundamental problem here, and that is I'm getting inconsistent data. I could cite data that would show one side or the other side in the argument, and if nobody dug any further, they'd be none the wiser, and they say, oh, okay, it does cause this thing, or no, it doesn't cause these things. The bigger problem here is that statins are complex chemicals with complex reactions, and they reduce LDL and triglycerides in most people, but we have to ask, who benefits? People with familial hypercholesterolemia may benefit from this reduction in LDL. People with low quality LDL, pattern B, oxidized LDL, for whom lifestyle changes just didn't help, they may benefit. And people in secondary prevention may benefit. Now, I know that's controversial. I've been asked to look into that, and I am going to be looking into that a little further. Any other use is an off-label use, and that's the problem. We're talking about preventing colitis, or maybe causing colitis, or preventing glaucoma. Associations with colitis and glaucoma, they're less pronounced than the ones that the pharmaceutical companies claim for the cardiovascular event reduction. And those, to me, like I've said before, they don't impress me very much. These impress me even less. Adverse effects, however, run between 5% and 30%, depending on who you want to listen to. I typically use 20 to 25% of people have statin adverse effects that affect their quality of life. But the adverse effects don't really care why you're taking the drug. The adverse effects are going to occur if you're taking it to lower LDL and you get adverse effects. Well, guess what? If you stop taking them for LDL, but then you start taking them to prevent colitis or to cause colitis, if that's what you're trying to do, you're still going to get adverse effects if you had them when you were taking it to lower LDL. The trade-off is even worse for these other conditions than it is for the cardiovascular conditions, because the relative risk reductions, even in the papers that are promoting these things as treatments for these conditions, these relative risk reductions are next to nothing. So what is the bigger issue? These are tiny effects. For example, a 10-year number needed to treat of 200. Okay, we're going to treat 200 people for 10 years with statins. 60 of them are going to have adverse effects if the 30% adverse effect levels hold. And one of them is going to avoid cancer? I mean, that to me sounds like statistical noise. I don't care what the statistical significance says. Once you're getting down to the level with numbers needed to treat in the triple digits, it's all noise. It's meaningless. The 2 to 7% relative risk reduction in a condition that affects 1.86% of the US population results in an absolute risk reduction of between 0.03%, not 3%, but 0.03%. That's a number needed to treat of over 3,000, and 0.13%. Again, not 13%, but 0.13%, which is a number needed to treat of around 770. Those are just useless treatments, yet they're being promoted as, oh, the next big thing that we can give people statins for. So what's happening here is that researchers are dancing around the edges between clinical relevance and statistical significance, yet they're still advocating that we start giving statins for all sorts of conditions. So even when clinical studies show reductions in a disease, there are cases where the statins can actually cause the undesirable outcome, and the problem is it's usually not recognized as the cause. They'll look at it and say, oh, I guess the statins didn't help prevent this in this case, but it's probably best to keep them taking them when the statins could actually be the cause. So we've always got to be aware of that. So what's my point in all of this? I have to ask this question. Do we want to take a drug that's specifically intended to disrupt the normal functioning of our livers for a small and possibly non-existent benefit in some completely unrelated area? That's a shotgun approach to medicine. We're just going to aim at a target, we're going to pull the trigger, we're going to send a bunch of birdshot at the target, and some things are going to seem to hit just out of coincidence. That doesn't make us a marksman. Same thing here. When I see the medical community looking at these tiny, tiny effects and saying, oh, more reason to give statins out, well, who benefits from that? It's the statin manufacturers. So that's my opinion on this use of statins for these off-label purposes, and the studies that show what the benefits are. They're garbage. They're so small as to be meaningless, and I don't want to disparage the people who are doing the studies. They're doing the studies and they want to find out if there is actually a benefit, but they're losing sight of the fact that the benefit is minuscule. So if you appreciate this content, please like, share, subscribe, and comment on this topic or others you'd like me to cover. And if you haven't seen this video, I recommend you take a look at it now. Thanks for listening.